Welcome to the PG orientation program that we always organize by WAOIV in KPC Medical College like every year. I think everyone has already got the agenda, like the schedule, it's in the WhatsApp group. So we'll start with chronic otitis media, and basically this time we have kind of divided it into a practical oriented teaching. So we have divided it into four parts. First is the case presentation, then the discussion part will be taken up, then the audiology and the allied part, and the CT scan, the investigation. And this topic will be moderated by our Professor Sir, Dr. Shomin Sir. So I'll like to hand over the mic in order to start the class.
Good morning, সময় নষ্ট করব না। COM important এবং for all practical purposes this will be the long case if it is available. যদি COM available না থাকে, then other cases will be given as long cases, but COM for all practical purposes will be the first preference. So COM পুরো মানে প্রোগ্রামটার জন্যই বলছি, মুখ বন্ধ করে থাকিস না, কেননা স্যাররা বলবেন, স্যারেদের বলাটাই ইম্পর্টেন্ট নয়, তোদের বলাটাই ইম্পর্টেন্ট। সো ওপেন ইউর সেলফ আপ। যদি মনে হয় যে কোনো কোয়েশ্চেন এর আগেও তার উত্তর দেওয়ার সময় আই ফাম্বলড অর আই এম নট শিওর অ্যাবাউট দ্য আনসার অফ দিস কোয়েশ্চেন, যেটা আমি আগে ফিল করেছি, ইউ ক্যান অলসো পুট দ্যাট কোয়েশ্চেন টু আস। আমরা কালকে লাস্ট সেশনটা ডাউট ক্লিয়ারেন্সের জন্য রেখেছি। যদি সেরকম কিছু কোয়েশ্চেন থাকে যেগুলো তোরা মনে করছিস যে সেগুলো একটু ক্ল্যারিফিকেশন দরকার, সবগুলো যে আমাদের কাছে অফ হ্যান্ড ক্ল্যারিফিকেশন থাকবে তা নয়। তো আজকে যদি তোরা সেই কোয়েশ্চেনগুলো আমাদেরকে দিয়ে দিস, তাহলে কালকে সেকেন্ড হাফে উই ক্যান ডিসকাস দোজ কনফিউশনস অর ডাউটস। COM আমরা এবারে কেস বেসড ডিসকাশন, দ্যাট উইল বি মোর লাইভলি। আমার মনে হয় যে যেমনভাবে প্রশ্ন করা হয় সেইভাবে করা হবে, যেরকমভাবে তোমরা পরীক্ষা ফেস করবে সেইভাবে। তো সেভাবে প্রথমে আমরা একটা আউটলাইন অফ দ্য পেশেন্ট, লং কেস 1 ধরো, তো আমরা আউটলাইন পেশেন্টের যা ফাইন্ডিং আছে তার একটা আউটলাইন দেব। সেটা দেবেন ডক্টর অজয় খাওয়াস। এটা পাওয়ার পয়েন্ট প্রেজেন্টেশনে আছে। তারপরে প্রফেসর রামানুজ সিনহা তোমাদেরকে বলবেন যে তোমরা কীভাবে হিস্ট্রি নেবে বা ক্লিনিক্যাল নোটস কীভাবে রাখবে, যে পয়েন্টগুলো মিস হয়, কারণ 10 মিনিট, প্রত্যেকের ভাগে 10 মিনিটের মধ্যে অত কিছু বলা যায় না, এবং তারপরে তোমাদের যা কোয়ারি থাকবে সেগুলো আমরা শেষে ডিসকাস করব। নেক্সট ইম্পর্টেন্ট থিং ইজ ডায়াগনোসিস। হিস্ট্রি নিলে, হিস্ট্রি লিখলে, সাবমিট করলে, নাও ইউ হ্যাভ আ ডায়াগনোসিস, দ্য প্রভিশনাল ডায়াগনোসিস অ্যান্ড দ্য ডিফারেন্সিয়াল ডায়াগনোসিস। সো you will have to defend your diagnosis. Defending your diagnosis will be discussed by Dr. Indranil Sen. Now comes to investigations. Audiological investigations will be discussed by Professor Sumanto Dotto, and radiology and other investigations will be discussed by Dr. Soposachi Gon. Now the treatment options. What are the treatment options we have? Will be discussed by Professor Bibhas Adhikari. And the surgical options and surgeries, complications, this will be discussed by Dr. Arindam Das. And at the end, the follow-up and the prognosis. You are doing many things, you are diagnosing, you are treating, but what is the expectation? What are the complications? What are the problems you face? How you convince the patient to follow your directions? So, follow-up and prognosis will be discussed by Colonel Ajoy Mollik. So, let us start without delay the case presentation by Dr. Ajoy Khawas.
Good morning. So, this year we have changed little bit in this program. Previously we have done on the discussion on the COM. Now this is only the practical orientation examination. So, I am just giving the brief of the case. This is not a summary and neither a proper history. Just brief of the case. So you know the history is important, because if you take the proper history, 90% diagnosis will be confirmed on that basis. So your history, and in the practical, the examination start with the history. Whatever you write in the history, that is the more important, and what the way exam will go on the basis of the history. So first thing is the history taking. You already know how to take the patient particulars, what you have to write in the patient particulars. I am not going. Next thing is the chief complaints. Most important thing, you should write the chief complaints. These patients have the chief complaints discharged from the left ear since last years and diminished hearing in the left ear since last 8 years. Now come to the history taking. There is the history of present illness and the others history. So on the history taking, first is the discharge. You have to write the discharge characteristics, and on the basis the discharge characteristics, the diagnosis will be depend. So on the left ear, insidious onset, continuous, scanty, yellowish, pus-like, non-sticky, foul smelling, occasionally blood tinged, not aggravated during cough and cold, partially relieved with oral or topical medication. So during the history taking, the ER discharge, the characteristics, also the aggravating factor, relieving factor, that should be mentioned. Next is the hearing loss. The left ear hearing loss, insidious in onset, gradually progressive, no history exposure to drugs or loud sound, no aggravating relieving factor, no history of fluctuation. These are the points. And the others negative history you have to take, because to rule out the complications others than the COM, you know, usually in your exam you get the long case of COM. So others negative history, that is earache, reeling sensation of head, ringing sensation in ear, fever, headache, neck pain, vomiting, deviation of angle of mouth, drooling of saliva, etc. You should ask, and that all are negative in this patient. No history of nasal obstruction or nasal discharge. Particularly for the any nasal pathology is present, you should rule out. So now come to the examination. This is the brief examination, not the details. Important thing, you have to draw the local examination and the ER examination, right and left ear. This is the otoscopy finding, and this is the drawing, schematic drawing. You have to draw the diagram in your papers during the examination, practical exams. So what are the finding? Left ear, that is the retraction pocket in the posterior superior part of the pars tensa with white epithelial plaques, fundus not visible, rest pars tensa grade 4 retracted, 4 certain malleus of handle of malleus, posterior mallear fold prominent, and the stage 4 or 5 attic retraction with epithelial flakes, also probable scutum erosion, right ear grade 1 retraction, pars tensa, loss of cone of light. And this is the tuning puck. These are the tuning puck test. Usually in your exam, usually we should do the serial tuning puck test. But if not, you should take all the tuning puck. Why you should do, that will be discussed in the later on, why you should do the serial tuning puck test. And these are the tuning puck test finding, and the OABR is lateralized to left ear, and the absolute bone conduction test is not reduced in the both ear. Facial nerve and the vestibular examination are normal, and others all systemic, others neck examination, larynx, necks, all those are normals. So now come to the provisional diagnosis. You have to, after the, make the provisional. This is a squamosal disease, chronic otitis media of left side, which side, then you should mention the which the variety, that is the squamosal variety, whether it is active or inactive. This is the active stage as the discharge is present. So without any complications or without any, or with severe conductive hearing loss, without any complications. This is the way you have to make the provisional diagnosis. So now I will hand over the mic to Professor Somendranath.
So now you have seen the case, you have asked the patient your relevant questions, now you have drawn the diagram. তাহলে এরপরে তোমাদেরকে তোমাদের হিস্ট্রিটা লিখতে হবে 45 মিনিটস টাইম, যে টাইমের মধ্যে তুমি পেশেন্ট এক্সামিন করবে এবং তার হিস্ট্রি লিখবে। কাজেই ডোন্ট মেক ইট টু মাচ ইলাবোরেট। তোমার মেন থাকবে এই ডায়াগনোসিসটা। মেন কাজ হচ্ছে ডায়াগনোসিস। ডায়াগনোসিসটাকে খেয়াল রাখবে, ডায়াগনোসিসের ফেভারে যে পয়েন্টগুলো সেগুলোকে ভালো করে বলবে, এবং অন্য ডিফারেন্সিয়াল ডায়াগনোসিস যেগুলো আছে সেগুলোকে নালিফাই করে যে পয়েন্টগুলো সেগুলো বলে। সো ইম্পর্টেন্ট পজিটিভ অ্যান্ড নেগেটিভ পয়েন্টস তোমরা লিখবে। ক্যারেক্টার অফ ডিসচার্জ, যেটা নিয়ে খুব ওকে, সো sometimes there are confusions about the character of the discharge. So character of the discharge will be discussed, described by the patient's own words when you are writing the history of present illness, and your own assessment when you are examining the patient and you are writing down your otoscopic findings and character of the discharge. So this character of the discharge should be clear, and it should be all the points should be mentioned. You start the history from the onset. It may be insidious. So start from the onset and go down. Once you write down the history, you check your history from backwards. So your diagnosis. What are the points in favor of your diagnosis? Which are the points that nullify the differential diagnosis? All these should be mentioned. Here has two functions, so never forget to write down about the vestibular function tests. Sigillization, Sigel's pneumatic speculum. You must all be competent in using the Sigel's pneumatic speculum, not by pressing the triggers you check whether there is any nystagmus or not. So I will hand over the microphone to Professor Sinha for the details of history writing. If you have any queries, if you have found any difficulty in writing down the details of the patients and the diagnosis, you can ask him any questions. Professor Sinha.
Hello. I think I am audible. It will not produce much noise to you too. Okay. So all welcome. I think you will do well in your examination. But in our state, particularly in the eastern India, CSOM is a very common disease. And there are many villages where we don't have any physician to take the case, to tackle the case. So, and being a ENT specialist, you must know how to tackle the case. Proper examination setup is not there. But you have to, from the history, you will be able to you will come to a conclusion what are the type of the disease. You take a permission from the patient that you are examining the patient. This is the most important. And for the female patient, female examiners, there is no problem. But in case of, you have to take an permission from the patient. Now what you will do from the beginning, what she will say. A person with this chronic suppurative otitis media, what is the type of the discharge is very, very important. What are the different types of discharge in chronic suppurative otitis media?
So if it is a squamosal variety of COM,
You don't know.
okay, if the discharge may be either scanty or profuse, we have to see that first. Whether it is
Discharge is-
scanty or profuse, then we have to see that is the amount. Then we have to see for the color of the discharge, whether it is greenish, whitish or colorless. We have to see for the nature of the discharge, whether it's purulent or mucopurulent or mucoid. Then we have to see look for any foul smell in the discharge, and then we have to see if there is any blood tinge or blood mixed in the discharge.
Okay. And with medication,
Any aggravating or relieving factor, if there's any history of getting relief or decrease in discharge with use of ear drops or any kind of medication.
one thing you have not mentioned the duration.
Yes, duration, sir. Duration, onset and duration. So for how long it has been there, and the onset, whether it is insidious in onset, we have to mention that also, sir.
from the point of odor, from the point of smell of the discharge, how will you differentiate? It is
So
a
fa-
squamous variety or it is a
So usually
Tubotympanic
foul-smelling
variety.
discharge indicates a squamous disease and non-odorous discharge. Foul-smelling discharge indicates a squamous disease because of the destruction of bone involved by the proteolytic enzymes in squamosal disease. Whereas in case of non-foul smelling, it is more indicative of a mucosal disease.
okay. And regarding hearing loss, what will you say? What will you ask the patient? Hearing loss. What are the types of hearing loss or severity of the hearing loss? What will be your question to the patient? Severity of the hearing loss.
Severity of hearing loss, if it is mild or severe. I have to ask the patient that from what distance he
Able to hear.
able to.
So what is your expectation in case of conductive hearing loss, or how will you correlate this to? Whether it is a conductive variety or it is a sensory neural variety from the hearing loss. And whether there is any, with the hearing loss, whether there is any additional symptoms.
In case of sensorineural hearing loss, there will be additional symptoms like tinnitus, vertigo. There may
Tinnitus.
Sudden.
So what is tinnitus? You said, what is tinnitus?
So tinnitus is the ringing sensation of the ear. It is due to the cochlear pathology. We generally feel the sensor. It is
It is a
absolutely
sensation of in the ear.
Sir,
It is a sensation of the sounds in the ear. So there is also sounds in the ear.
sir, it is
Tinnitus is a sounds in the ear in absence of a vibratory source in the environment. Tinnitus is a source. Tinnitus is a sensation of sounds in the ear in absence of a vibratory source. This is the vibratory source. In absence of a vibratory source in the environment. That is tinnitus. Next. So how will you differentiate these two discharges? One is tubotympanic and the other is scanty and purulent offensive smell. So what is the type of smell? Offensive?
Sir, the squamosal variety or the adiquantral variety is associated with continuous foul-smelling, scanty discharge.
Discharge. What is the type of smell?
Smell is foul-smelling, the fishy smell, sir. Fishy smell, sir.
In your city, where you will get this type of smell?
In your city, where you get this type of smell?
In your city,
In my city, sir.
particular there is a smell. Fishy smell
This is smell where you will get.
So in the market, sir.
in the market. In the fish market of Calcutta. In the fish market of Calcutta.
Yes, sir, yes.
So why this smell occurs? Why this type of smell you will get?
Sir, it is due to presence of anaerobic bacteria, sir, like bacteroids, and due to osteitis and granulation, sir.
Okay, they will discuss it subsequently. They will discuss it subsequently. Chalo. And do you expect any sounds in the ear? Any sounds in the ear? Any sounds other than
Tinnitus. Other than tinnitus.
other sounds? Other than sounds, any symptoms of dizziness or vertigo?
Yeah, there can be dizziness or vertigo. If there is any complication due to the unsafe CSOM, there can be.
And do you think in presence of loud sounds, there is a rise in the intensity?
Yeah, there can be.
What is this?
This recruitment.
What is recruitment?
When the loud sound is perceived by the patient more. When the sound is perceived by the patient more than usual.
Recruitment is an abnormal phenomenon. When there is a slight increase in the intensity of the sounds, it will produce an enormous increase in the subjective sense of loudness. ঠিক আছে? Subjective sense of loudness. Enormous increase in the intensity of the sounds, not in the frequency. It is not related with the frequency.
So if you have any queries regarding writing down the history, you can ask that. Regarding history, what you have written is correct. How you have drawn the diagram over all the 3 years is correct. Don't try to decorate the diagram. Whatever you draw is correct. Don't try to decorate and modify the diagram from what you have drawn over the years. So what you have done is correct. The diagram should show that there is foreshortening of the handle of malleus, the attic pathology, and the other ear also show what is there, the condition of the other tympanic membrane, because other ear examination is also important. Now, here the history. History is important, as in this case there is retraction of the tympanic membrane, there is the pars tensa, there is retraction of the attic, there is retraction of the posterior superior quadrant, so global disventilation is there, and the history of this recurrent episodes of respiratory tract infection in the childhood is important here. So what is the condition of the tympanic membrane? Whether there is selective disventilation or there is global disventilation, you should have your history tailored according to that. সেইভাবে কিন্তু হিস্ট্রিটা তৈরি করবে, হিস্ট্রিটা প্রথম থেকে করবে. Now you go back from the diagnosis to see if all the points are written there or not. Regarding the character of the discharge, when the patient says it is stringy, it is foul smelling, or it is pus like, he may say that. But when you write, you can write in the medical terms that it is mucoid. Patient will never say it is mucoid. You can say it is purulent. Patient will never say it is purulent. So in this way, the patient's version and your version will be different, and write down accordingly when you are writing history and when you are writing your findings in the otoscopy. Both the years should be written in separate columns. What you have done is correct. Don't try to modify at the last minute. We have seen that the tympanic membrane will look better if I draw it in this way on the table. He draws a tympanic membrane which is absolutely bekar ka cheez hai. So whatever you have drawn, you write that. Okay, and this handle of malleus, foreshortening, it should be seen. Okay, now you have a diagnosis and you have a provisional diagnosis. So there are differential diagnoses, and you will have to defend your diagnosis. Why you have come to this diagnosis? For one point, you have said that it is a squamosal disease. In no book there is written as squamosal disease. It is a mucosal disease and a squamous disease. So try to maintain the accepted terminologies. Now it will be Professor Indranil Sen who will teach you how to defend your diagnosis.
Good morning, everyone. Now, the defending the diagnosis is something like pleading in the court of law. As strongly you can plead for the case in the court of law, the more successful you are. Now here, what do you exactly mean by defending your diagnosis? So you have made a provisional diagnosis. By the way, how many types of diseases are there known to medical science? Any guess? How many diseases are known to the medical science? You should know. Approx. No answer from the audience. It's approximately 25,000 plus. I'm not wasting time. You should go to ICD-10. Come on, man. All the diagnoses are there in ICD-10. Okay. So approximately 25,000 plus diagnosis is there, of which we are dealing with one of them. Now, how do the diseases differ? How the diphtheria differs from tetanus? Simply, man, it's simply two storylines. They are two different storylines. So all the disease diagnosis is essentially a storyline. If I say that there was a prince in Ayodhya called Ram, his father was Dasharatha, you will say, sir, it's a Ramayana. And if I say that there were five Pandu and you will say Mahabharata, sir. So how do you diagnose it? Because of the storyline is fixed for a diagnosis. Similarly, for this diagnosis also, chronic otitis media, there is a storyline. Chronic otitis media, mucosal variety, there is a storyline. And how that storyline starts? Storyline starts from an event sequence. Event 1, according to chronological order. So if you have a chronological order, so initially the thing starts as event 1, then event 2, event 3. In this way, event N or the last event of any disease is death. We don't go up to that. So we stuck somewhere here. Say we are getting the patient at the event of 546, where this picture will be available. So before that, there are 545 events chronologically, logically, and you have to explore as many possible of these 545 events from the patient and from your examination. And that should be placed chronologically. So our sir has said, when you are stating the history, it must be in a serial chronological order so as to draw a clear picture in the mind of your examiner about the exact natural history of a disease. The more successful you are in drawing the picture of the natural history of your diagnosis in the mind of your examiner, the more you can defend your diagnosis. Examiner will not be able to poke a single point there. Remember, if you overlap it, if you mess it up, the fault lies with you. So you should not mess up. So as sir has rightly said that what should be the discharge? Every symptom and sign, what do you discover? Now, these are the events what you get from the history. Up to this one, say event number 544. Now at this point, you come in touch with the doctor. Now you are going to examine your patient. How do you know about your surroundings? You see, you touch, you smell, you test. And similar, all the faculties should be applied to the patient also. You see the patient, inspection. You feel the patient, palpation. You listen to the patient, auscultation. All the faculties should be applied, and accordingly, inspection, palpation, percussion and auscultation must be mentioned in the examination part. As sir has previously said, regarding every finding, there are some sub-points. You are not allowed to miss a single point in the history in order to have a solid defense for your diagnosis. Say for the discharge, it's onset, duration, so there is a part of the history. Onset, duration, periodicity, aggravating factor, relieving factor. So these are the points of history. It has already occurred. Now you come to the diagnosis, don't mess it up. As an examiner, I'm a very notorious examiner. If you mess up these two things, I will just pull your leg up. But when you are examining, these points should be staying apart. You are not supposed to go for all these things. Examination, quantity, amount, profuse in amount or scanty in amount. Color, it is yellowish in color. It is blood tinged. What is the nature of the discharge? Is it a continuous discharge or it is a pulsatile discharge? That must be described. Each and every broad and minute point of every symptom must be explained or described according to the chart available. Don't omit a single finding. Whenever you're getting a swelling, always get site, size, shape, surface, margin, consistency, margin slipping under the finger, ballotability, auscultation findings, the transillumination finding, whole array of the examination thing must be followed meticulously. There is no exception. So as far as you can fix with the diagnosis, when you are actually corresponding in your history statement, the statement of your history and clinical examination in a continuous, uninterrupted, not overlapping way, the more you are solid in defending your diagnosis. Now the question will come. Our eyes has got limitations. Our ear has got some limitations. Our palpation has got some limitations. And therefore, we extend our perception, these faculties, a bit more. Suppose what's happening inside the chest of him, I can't see. Therefore, I extend my eyes with a X-ray and I can see what is happening inside his chest. So all the investigations are essentially extension of our knowledge faculty of the doctor. Okay, when you do the chemical tests, previously in the medieval period, doctors used to test it directly on their, how does it test? Is it testing sweet or sour or something? But now we don't do that, we go for the chemical test. But that is essentially extension of our faculties. So in this way, you make a defense of your diagnosis, the more solid every point is made in the natural history. So always keep in mind that a disease has a dedicated, unique natural history. But there will be some variations. And those variations are differential diagnosis. And there will be certain negative points which you need to pick up from the history and clinical diagnosis in order to make a negative statement about the differential diagnosis. Sir, had it been a such and such thing, the thing would have been such and such thing. It is not there, therefore it is not that. So that's the logic. So when you are giving a provisional diagnosis, pick up as many as possible positive points from the history as well as clinical diagnosis. And for solid defense of your diagnosis, never overlap the history part with the examination and examination part with the history. Patient will say something, but every something has to be corroborated by clinical examination. If you fail to corroborate a single statement of the patient in your examination, then your defense is doomed. The examiner will get the point to just rip you up. Simply, patient has stated about the discharge, but you did not verify whether a discharge is there in the extraordinary canal or not, and neither you corroborated what were the statements of the patient and your finding, then you are doomed. So that is called a defensing. It is very simple, but it is very meticulous. Each and every point of your natural history must be elucidated in your the history point of view, and during the examination, what are the things to be found here? At the point of examination, where the patient is coming in contact with the patient, now the discussion will come, what can happen? That is a speculation and prediction that will come in the case discussion or oral subsequently. Any question? Any question? Case defense is very simple if you understand it. Try to understand the logic. The logic is to follow the natural history perfectly, without leaving a single clue. Follow it. Suppose this is the chronic subacute media of unsafe variety or the squamosal variety. You know what are the pathogenesis. You should know the pathogenesis. It is completely different from the mucosal variety because the pathogenesis is completely different. The cholesteatoma, where it grows, as it grows, different theories are there, and accordingly there are gradual step 1, step 2, step 3, step 4 destruction, chronologically depicted. Coming to such variations, some variations may occur. Why? Suppose, simple logic, suppose I am drawing a straight line on a straight surface, it will look straight. But if I am drawing the straight line on a wavy surface, it will look wavy. But that doesn't mean that I have drawn something else other than a straight line. So there are certain variations in certain patients. Suppose a narrow extraordinary canal, or the patient also had got a previous disease in the ear. So the signature of the disease on that patient may be a bit different because the surface is not uniform. But that has to be appreciated only by your clinical acumen. That this is chronic subacute media. Suppose a person has suffered from tuberculosis, and then you are taking a chest X-ray of a bronchitis. You should understand that I am not seeing a clear-cut case, but it is a past history's importance is there. In the past, the patient suffered from a tuberculosis, and now I am saying this, so it must be interpreted accordingly as if it is not a fresh case. So certain variations will be there in your clinical finding, but as long as you can follow it, your defense is solid. Any question?
If you have any questions, you can ask, or we will discuss it tomorrow in the second half. So, that part has been discussed. What are the points in favor of your diagnosis and why the differential diagnoses are excluded? Now, to confirm your diagnosis, you will have to go for certain investigations. So now, the examiner will ask you what are the investigations you want to go for. So first we will discuss about the audiological investigations that are very important. So audiological investigations and their, how you present these audiological investigations, what are required, will be discussed by Professor Sumanto Dotto.
Audiological evaluation of a patient with ear disease. Present case, the present scenario, we are having discharge from left ear as well as hard of hearing from left ear for 8 years. How do you evaluate hearing tests for this patient? We have limited time, 10 minutes is allotted for this audiological evaluation, and I shall finish by 10 minutes. Before investigations, you have to clinically evaluate hearing also. Clinical evaluation is when the patient enters in your clinic or chamber. From that phase, the patient who is having severe deafness will have a vacant look, will try to study, will try to read your lips. If you carefully look the entrance of the patient, that may particularly guide you to some amount of assessment of degree of hearing loss also. So when the patient enters your chamber, your clinic, you have some assessment. Later on, during taking history, you will have eye-to-eye contact. If sometimes you wear mask or you turn the face from the face of the patient may be confused if he or she is having severe degree of hearing loss. From that point of view, you start your thinking that there may be mild, moderate or severe degree of hearing loss. So history taking is very important, and part of history is entrance of the patient to your chamber. Number 2, hearing tests. After your clinical examination, after your otoscopic examination, you go for hearing tests. Hearing tests starts with conversational hearing test and whispered hearing test. Conversational voice test is the standard voice we speak. Whispered voices are reduced voice. You have to assess both conversational voice and whispered voice for that particular patient. So you get a guidance. After that you go for tuning fork tests. Tuning fork usually we use, if we use a single tuning fork, it will be 512 Hz. But if you go for serial tuning fork tests with 256, 512 and 1024, you may have a clear idea of degree of deafness and to some extent any other associated lesion. How? If you get 256 Hz negative, RINI, but positive for 512 and 1024, that particular person is having mild degree of deafness. So if a person having mild degree of deafness, 15 to 20 dB, if you do only 512 Hz, RINI may not be negative, RINI may be positive. So you may have at a point of time have some confusion that this particular patient is either not responding correctly or you are getting faulty response. So if you go for serial tuning fork test, you have an idea of degree of them. Similarly, 512 Hz is also negative, 256 Hz negative, 512 Hz negative, but 1024 is positive. Then moderate degree of deafness. And if all the three frequencies, 256, 512 and 1024 are negative, then it may be moderate to severe degree along with some degree of ossicular disruption. So mere hearing tests and tuning fork tests without any audiological investigation, without sending the patient to audiological laboratory, you can have a clear assessment of type and degree of hearing loss in many cases. Now let us go to the pure tone audiometry. In pure tone audiometry, we know that there are two curves. One is bone conduction curve, one is air conduction curve. Bone conduction curve is always above air conduction curve unless your technique is faulty or the patient is malingering. In case of malingerer or faulty technique, you may have a reverse curve. Otherwise, bone conduction curve is always above air conduction curve. And for remembering, bone conduction curve are plotted with broken line, B for bone, B for broken line. Air conduction is a continuous curve. দিতে হবে তাহলে এইটা একটু তোমরা দেখে নাও, এটা প্রজেক্ট করা যাচ্ছে না। তো bone conduction curve, air conduction curve, there should be some amount of airborne gap. For normal hearing, we do not have any airborne gap, and the bone conduction and air conduction curve both. Etu pass kore dao. Three types of deafness we know: conductive deafness, sensory neural deafness, and mixed deafness. Other situation is a normal person. So what will be the configuration of the audiogram? Audiogram is nothing but the plotted curve. Pure tone audiometry is the process, and pure tone audiometer is the machine concerned. So in the pure tone audiogram, if we get a bone conduction curve at normal level, air conduction curve following that, and there is no significant amount of hearing loss, so that is the situation of a normal person. But if the bone conduction curve is at normal level and the air conduction curve has come down and there is significant amount, more than 20 dB of airborne gap, then this is a situation of conductive deafness. If both the curve come down, both bone conduction and air conduction, and there is no significant airborne gap, then this is a sensory neural situation. And a mixture of the two, that is bone conduction curve has come down and air conduction curve has also come down, and there is significant amount of airborne gap, that is mixed hearing loss. Is this clear or any confusion till now? Again I repeat, for normal person, bone conduction curve, air conduction curve are parallel without any significant airborne gap. For conductive deafness, bone conduction curve is at normal level, air conduction curve has come down, and there is significant airborne gap. Significant means more than 15 to 20 decibel. And in sensory neural deafness, both the curve will come down and there will be no airborne gap, no significant airborne gap. They are parallel and near to each other. And in mixed deafness, both the curve come down and there is significant airborne gap. Any confusion till now? We are focusing on audiological assessment of this particular patient of left ear discharge and left ear hearing loss. So we will stick to this only. What will be the finding of this particular patient? এই পেশেন্টের অডিওগ্রামটা কি হবে? যে পেশেন্টটা আমাদেরকে প্রেজেন্ট করা হয়েছে আজকে, লেফট ইয়ার, বসে বল, লেফট ইয়ার ইয়ার ডিসচার্জ and left ear hearing loss for 8 years. What will be the audiogram?
As it is commerce type, there will be a conductive type of hearing loss. Sorry, mixed type of hearing loss.
What will be our tympanogram for this particular patient? For left ear and right ear. Somebody else, you.
B type of tympanogram will be there. So, it will, no sir, only for the left ear B type.
When it is asked what will be the tympanogram for this particular patient, you have to mention both left and right,
okay.
Isn't it?
That's
so for the left ear it will be a B.
B
What
type.
what do you mean by B type of curve?
So it will be a flat tympanogram. There will be
Flat. Is there any difference between low based flat and high based flat? And if yes, how do you differentiate?
So don't know sir. Don't know sir.
No. Anybody in the audience? Low based flat B and high based flat.
So if there is any perforation, then the middle ear and the external ear volume will be combined together. Therefore, it will be high volume flat. Flat curve. And if it's otitis media with effusion or adhesive otitis media, then it will be low type curve.
For the high based flat, do you have any change in the curve with act of swallowing? and why? একটু কার্ভগুলো দেবে, অডিওগ্রামগুলো একটু দাও, ওখানে ফোকাস করা যাবে।
So volume will be raised, sir.
If there is a perforation in the tympanic membrane, if there is any perforation in the tympanic membrane, the flat curve
Compliance-
will be a high based flat because
Compliance will
the
be
air volume of the external canal is also added. But that high based flat will be neutralized with act of swallowing when the eustachian tube functions. If the eustachian tube is functioning, that high based flat will be a bit neutralized and again will come to high base if the eustachian tube is patent and normally functioning. এটা কি দেখানো যাবে? দিয়ে দাও। And for the right ear it will be type A curve. This is Jargar's classification of tympanogram. Type A, type B, type C and special variety of A, AD and AS. But there is another classification which is called Feldman classification, where the type of the curve is described, both the middle ear pressure and the compliance. So type A curve in Feldman will be described as normal middle ear pressure, normal compliance curve. Flat curve in Feldman's classification will be described as no peak in middle ear pressure and compliance cannot be assessed. For type C, there will be negative middle ear pressure and diminished compliance. Type AD, normal middle ear pressure, high compliance. And type AS, normal middle ear pressure, low compliance. আমরা একবার দেখে নিই ওখানে কি দেখাচ্ছে, হবে কি? দিয়ে দাও, এটা দিয়ে দাও। দেখিয়ে বলে দিন স্যার। দেখা যাচ্ছে না ওখানে, থেকে অনেক পরিষ্কার করে দেখছি। এইটা লেফট ইয়ারটা কি একটু বলে দাও, এটা এই কেসটার সঙ্গে রিলেটেড নয়। বলবে আমাদের অডিওলজিক্যাল অ্যাসেসমেন্ট কিন্তু হয়ে গেছে, আমরা পেশেন্ট যখন ঢুকবো তখন থেকে দেখব, তারপরে তার ভয়েস টেস্ট করব, তারপরে তার টিউনিং ফর্ক টেস্ট করব এবং তার অডিওগ্রাম টিম্প্যানোগ্রাম করব। ম্যালিঞ্জারারকে যদি টেস্ট ছেড়ে দাও, ম্যালিঞ্জারার যদি আমাদেরকে ডিটেক্ট করতে হয় কী করব, ম্যালিঞ্জারার স্পেশাল টেস্ট কী করব, ম্যালিঞ্জারিং যদি কেউ করে হিয়ারিং লস নিয়ে কিছু স্পেশাল টেস্ট আছে, স্টেনভার্স টেস্ট অ্যান্ড আদার্স। এটা এই ডিসকাশনের পার্ট নয়, টাইম আমাদের পারমিট করবে না, আমার 10 মিনিট হয়ে গেছে, আমি ছেড়ে দিচ্ছি। কারোর কোনো কনফিউশন থাকলে জিজ্ঞেস করতে পারো, বা কালকে যখন ওপেন সেশন হবে। এই কেসটার অডিওমেট্রি ফাইন্ডিং তো আমরা ডিসকাস করেছি। এই কেসে অডিওগ্রাম কি পাবো হয়েছে তো? দিস পার্টিকুলার কেস উইথ লেফট ইয়ার ডিসচার্জ and left ear hearing loss for ACS. What will be the audiogram finding for this particular?
There is moderate conductive hearing loss with type B tympanogram. Conductive hearing loss. Mix also has.
মাস্কিং সম্বন্ধে আমাদের কি আইডিয়া আছে? মাস্কিং
Sir, in case of audiometry, sir, why is that every time a bone conduction curve is always at the higher level? Like for instance, if we do a Rene test, we have been explained that.
It's a long discussion beyond the scope of this particular session for 10 minutes. পরে ডিসকাস করবো এটা নিয়ে, কেন বোন কন্ডাকশন কার্ভটা সবসময় উপরে থাকে ইন কম্পেয়ার্ড টু Rinne's test where air conduction is better than bone conduction. এটা একটু কন্ট্রাডিক্টরি লাগছে। আমাদের Rinne's test যখন করি তখন ফাইন্ডিংটা AC greater than BC, air conduction greater than BC is supposed to be normal. But in bone conduction and air conduction curve in audiogram, bone conduction curve is at better level than air conduction. This is a contradictory state. এটার এক্সপ্লেনেশন আছে, not purview of this class. মাস্কিং সম্বন্ধে কারোর কোনো আইডিয়া আছে? অডিওলজি, অডিওমেট্রি, পিওর টোন অডিওমেট্রি, এখানে মাস্কিংয়ের কোনো দরকার এই পার্টিকুলার কেসে আছে কিনা স্যার রিকোয়েস্ট করেছেন, তাই মাস্কিং for this particular patient. যেহেতু এর স্কোয়ামোজাল ডিজিজ আছে এবং মডারেট ডিগ্রি অফ কন্ডাক্টিভ ডেফনেস আমরা এক্সপেক্ট করছি, and the other ear, the right ear is normal. So supposedly interoral attenuation will be more than 40 to 45 decibel. So proper masking is a must. Otherwise there will be a faulty report. And there lies the question of shadow card. With severe degree of sensorineural deafness, if you do not mask the non-test ear, the sound from the test ear will be conducted to the other ear and you will get a moderate degree of conductive deafness. But when you use proper masking, that shadow will come down to much lower level and producing a severe degree of sensorineural deafness. This phenomenon is called shadow card. So masking for bone conduction, if whatever may be the situation, for bone conduction, every bone conduction test has to be properly masked, because interoral attenuation here 0 is the standard test for masking. And for air conduction curve, if there is difference between two ears more than 45 decibel interoral attenuation, then you go for masking. Without proper masking, any audiological investigation is not foolproof. And remember, with the pure tone audiogram, do not jump to the diagnosis. Go through your clinical profile, go through your Rinne's test, Weber's test and absolute bone conduction test with serial tuning fork test Rinne, and compare that with the properly performed, properly masked audiogram. আমাদের এখনকার ট্রেন্ডটা হচ্ছে ক্লিনিক্সটা বাদ দিয়ে পেশেন্টের হিয়ারিং লস উইদাউট ডুইং টিউনিং ফর্ক, সেন্ডিং টু অডিওলজিস্ট ফর দ্য অডিওগ্রাম, অ্যান্ড উইথ দ্য পিপিপি মডেল দ্য অডিওলজিস্ট ইজ ভেরি বিজি। কুইক ইন কুইক আউট টেকনিক, গেল একটা কার্ভ নিয়ে চলে এলো, সেটা কিন্তু তোমার পেশেন্টের সঙ্গে ফিট নাও করতে পারে। রিমেম্বার দ্যাট clinics is never obsolete, clinics is very important, and that starts from the entry of the patient, going through the history taking, doing the serial tuning fork test and other tests also, and then you go to the referral of the audiologist, and from the audiologist, whenever you get the audiogram, recheck it with your tuning fork findings. Thank you.
So here we differ from Scott Brown's textbook, and we consider tuning fork tests to be of superior value than pure tone audiometry if they are in conflict with each other.
You do not rely your tuning fork test as the ultimate. No.
Whispering voice test and speech test. So we should.
বুঝতে পারলাম তোমার কোশ্চেনটা শুনতে পাই।
Scott Brown, it mentions that we have to do free field speech testing.
Free field speech audiometry is not required for each and every patient. That is a separate.
No, sir, not audiometry, sir. Free field speech testing.
Free field speech audiometry.
No,
what
sir,
do you mean by free field speech testing?
So it is similar to speech test, but here whispering as well as speech both are tested.
Pardon?
Whispering test and speech test both are tested.
In conversational voice test and whispered voice test, there are so many confusion. What will be the standard distance for conversational voice test? Can you tell?
Sir, it's 60, 20. It's 60 meter.
Confusion. There is no standardization of the distance for conversational and whispered voice. Go from this book to that. আজকে সকালে আমি লোগান টার্নার দেখে এলাম, সেখানে বলছে 5.5 মিটার। 5.5 meter is the standard distance for whispered voice test, not conversational voice test. Whispered voice tested distance বলছে 5.5 meter, মানে 18 ফুট দূর থেকে নর্মাল একটা পারসনকে হুইসপার্ড ভয়েস বললে শুনতে পাবে কিনা সন্দেহ আছে। কোথাও 12 ফুট বলা আছে, কোথাও 18 ফুট বলা আছে, সেটা কোথাও আবার দুটো টেস্টের জন্য একই করা আছে। আমরা এই ছোট সেশনে কনফিউজিং টপিকগুলো না তুলে স্ট্যান্ডার্ড জিনিসগুলো, স্ট্যান্ডার্ড প্র্যাকটিসটুকু ডিসকাস করি, তাহলে বেটার হবে।
What is the practical handicap of a patient? Not the audiometry, not the pure tones. They are not present in the nature. So whether the patient can understand the speech or not. So speech discrimination score is the main thing where the patient feels the handicap. So pure tone audiometry, tympanometry, we consider it as psychoacoustic audiometry. So the handicap the patient feels and not according to the tuning fork. Those are for our benefit. So speech discrimination score is also very important where the patient feels the handicap. Now we are moving on to the radiological and other investigations. Professor Sabyasachi gone.
Thank you, Somendra. So apart from, hello, good morning to all. Apart from audiological investigations, we would like to do some other tests also. I divide them on the basis whether we are planning for a surgery or we are not planning for surgery, for better treatment or further treatment. So for surgery, we know we need some pre-anesthetic check of fitness, and that depends mostly on the anesthetist you want to work with. Because I have seen for uncomplicated mastectomy, some anesthetists also want to know regarding the RHO and blood grouping. So it largely depends on the anesthetist, whatever the test they require, you have to go for it. Apart from pre-anesthetic checkup investigation, other investigations are radiological and microbiological investigation and some blood investigation. So microbiological investigation, you know, you take a ear discharge and then send it for culture sensitivity, and that will decide the further course of antibiotic that you want to write. Next is blood investigations. Do you need any other investigation? If it is you need some blood investigation if it is a complicated mastoiditis. Like in case of sigmoid sinus thrombosis, you will get some spiky fevers, picket fence fever, and you need to do blood for malaria test also in those cases, and urine test also in those cases to rule out other causes of these kinds of fever. If it is labyrinthitis, patient will be presenting with fever. If it is meningitis, patient will be presenting with fever. So you have to rule out other causes of fever by doing tests for them. Now coming to the radiological investigation, why do we need to do radiological investigation? One is for planning of further treatment, and number two, to understand the disease process, the extent of the disease inside the temporal bone. So radiological investigations, do we do only CT scan? No. Radiological investigations are either X-ray, CT scan or MRI. So X-ray, most importantly, these three X-rays are written. One is law view, another is Scalars view, another is Townes view. In post-graduation education training program, very rarely postgraduates resident go to the radiology room and see the position of the patient. But sometimes examiner also asks that what is the position of the patient. So this is important. For law view and scalar view, the patient lies on the table or on the wall with the coronal plane, not coronal, sagittal plane parallel to the X-ray plate. The side we want to do X-ray, that is towards the X-ray plate. And for law X-ray, this angulation is 15 degree. For Scalars view, this is 30 degree. For Townes view, this is straight antero-posterior view with a fronto-occipital 30 degree obliquely placed. And we get view of both the mastoid together. In law view or scalar view, we see the affected side temporal bone. So what are the things we are looking for in the temporal bone X-ray? We need to know the size of the mastoid, the cellularity of the mastoid. So size of the mastoid, for size of the mastoid, there is a triangle which is known as periantral triangle of Sillinger. What is that? You can see the head of the mandible here, and this is the glenoid fossa. From glenoid fossa, you go make a line posteriorly towards the parotid notch. That becomes the superior boundary of the periantral triangle. Anterior boundary is along the anterior tympanic line, and a line which is drawn from the parotid notch along the sinus plate that meets the anterior tympanic, the line which is drawn along the anterior tympanic plate, this is known as periantral triangle. And we have to see how the disease process is beyond the triangle or not. We have to see the cellularity. According to the cellularity, the mastoid can be a pneumatic mastoid or a diploic mastoid or a sclerotic mastoid. So 80% of the cases we get pneumatic mastoid, rest 20% are diploic and the sclerotic mastoid. Can any one of you tell me the difference between the sclerotic mastoid and the diploic mastoid? what is the difference between diploic and sclerotic mastoid? In pneumatic mastoid, we know there will be mastoid antrum and there will be adequate air cells which are pneumatized. In diploic, the air cells will be lesser in number and smaller in size also. And there will be some marrow spaces in between those air cells. But in sclerotic mastoid, you do not get those marrow spaces. And the whole of the mastoid is sclerotic. Why some of the mastoid are sclerotic or diploic? Due to the deficient pneumatization. So you have to know also what are the theories of the deficient pneumatization, like Tumarkin theories, like Vitamix theories. These theories you should know. Now coming to other things, what you see, this is the most important area for X-ray mastoid is the aticoventral area, where the disease starts and extends. We have to also know the position of the sinus plate and the dural plate, whether the dural plate is low lying or the sinus plate is forward lying. If these two are present, then we say this mastoid is contracted mastoid. Our surgical plan changes. We do not go outside in, sometimes we change our planning to inside out surgery, mastoidectomy for these cases. We also need to know if there is any lytic lesion. So if there is any lytic lesion, that can be due to cholesteatoma. So what is the speciality of the lytic lesion? Biocholesteatoma. The margins will be smooth. What are the other differential diagnosis of the osteolytic lesions in the temporal bone? Post-surgical. The margins will be irregular. Any other that you can say? Tuberculosis, malignancy, multiple myeloma, okay? And also sometimes bigger size of bigger antral cell or periantral cell. That can also give rise to a feeling of an image of osteolytic lesion. So X-ray temporal bone, apart from X-ray temporal bone, what are the other X-rays that we should write? X-ray paranasal sinuses and X-ray soft tissue nasopharynx. If it's a child and if it is a tubotympanic disease, then a soft tissue nasopharynx to assess the size and functionality of the nasopharynx is to be done. Why that so? Because if the adenoid is enlarged, if there are other septic focuses in the nasopharynx or the tonsils or in the sinuses, then they must be treated in case we are dealing with a patient of tubotympanic disease. But if it is a squamous disease or aticoventral disease, in that case, that should be dealt first. So there is change of treatment plan. If it is a tubotympanic disease, the treatment will decide largely on if there is any septic focus lying or not. And then if there is no septic focus, then you can go for surgical correction. But if it is an aticoventral disease, you do not need to see any other septic focuses. You have to straight away go for the management of the squamous chronic otitis media. Next, let us go for the CT scan. Very briefly, I will not go with a video or cut by cut. I have given 3 cuts for the axial and 2 cuts for the coronal cuts. And I will go above downwards. Radiological, from the radiological department, the CT scan we get, they give it from the below upwards. But we work from above, so that's why this is convenient for us. So this is above the level of the attic area. Here you can see this is the large pneumatized area. This is mastoid antrum, this is aditus, and this is attic. All right. So this is lateral semicircular canal, and this is vestibule. What is this? This is the labyrinthine segment of the facial nerve, and this is internal acoustic meatus. So what are these two? These are the posterior semicircular canal. So I go one step down. Here this is the view of the epitympanum. So in epitympanum we know we get ossicles like head of the malleus, which is articulated with incus. Behind more when we go, we get body of the incus, then we get short process of the incus, which lies in the aditus and forms the incus buttons. So from anterior to posterior, this is head of malleus, this is incudo-malleolar joint, this is body of the incus, this is short process of the incus. All together forms the ice cream cone appearance. The ice cream ball is formed by the head of the malleus and cone is formed by the body of the incus and the short process of the incus. What is this? This is anterior tympanic recess. This is again mastoid air cells. What are these? Can anyone tell? Already written here. So this is basal turn of the cochlea, this is middle turn of the cochlea, and this is modulus. What is this? This is otic capsule, and this is internal acoustic meatus. So let us go one step down. Now we are at the mesotympanum level. So this is axial cut in the mesotympanum level. If you see from anterior to posterior, first there will be long process of the incus. So we will get a cut of the long process of the incus after, handle of the malleus first and followed by the long process of the incus, and after that stapes. So anterior to posterior you will get handle of malleus, long process of incus, then stapes. So here you can see that same thing. This is handle of malleus, this is long process of incus, and this is stapes. This is what is this? This is pyramidal eminence. So if you can identify pyramidal eminence, what will be the space lateral to it? That will be facial recess. If you can answer that facial recess, the examiner might ask you what is the importance of facial recess. So this is the window through which we do posterior tympanotomy. If you can answer that, then again come the question like what are the indications of posterior tympanotomy, and the examiner may go to the cochlear implantation indications and surgical technique, etc. So what is this space medial to the pyramidal eminence? That will be sinus tympani. Very good. So if you can identify the sinus tympani, there is another structure which is at the base of the pyramid, and then again it is going towards the stapes. This is the stapedius tendon. So what lies in the base of the pyramid or just posterior to the base of the pyramid? This will be the mastoid segment of the facial nerve. So all clear? So what is this? This is aqueduct of vestibule. This is round window niche. This is again, what is this? Septum, interscalar septum. This is basal turn of the cochlea, middle turn, and the apical term. What is this? Carotid canal. Okay. So now we go to the coronal cuts. So this is coronal cut. We divide it into from anterior to posterior. We go from anterior to posterior. There are two cuts. One is at the anterior level, another is the posterior level. So when we go to the anterior level, we will get the head of the malleus, right? So if you see the head of the malleus, then this will be the lateral process of the malleus. So what will be the space above the lateral process of the malleus? Prusak space. So this is the Prusak space. If this is Prusak space, then this will be lateral malleolar ligament. So what will be this? This will be scutum or the lateral lactic bony wall. So this spar is also known as spar of Chausse, C-H-A-U-S-S-E, spar of Chausse. When you do CT scan, you look into these two things. Radiologists look at these two things, whether this is eroded or not, and number two, intercasing of the ossicles. Now, coming to this, what is this? This is the tendon of the tensor tympani, because this is the medial wall of the mesotympanum, and medial wall of the mesotympanum, one structure is going to the malleus neck. So what can be that structure? That will be tensor tympani, right? So if it is tensor tympani, so what will be this structure? This will be processus cochleariformis, right? If you can identify processus cochleariformis, you get first genu. So at first genu, what will you get? You will get the tympanic segment of the facial nerve. And we know that here facial nerve makes a turn. So that's why it is known as first genu. So you get another segment of the facial nerve. This is known as labyrinthine segment of the facial nerve, right? So again here we are getting septum, this one. This is the basal turn, and this is the middle turn of the cochlea. So what is this? This is carotid canal, right? Anything else? And now the roof. The roof is by tegment. The area which forms the roof of the middle ear known as tegment tympani, and which forms the roof of the mastoid antrum known as tegment. Very well. So this is a large air containing area. This will be external auditory canal, right? So what is this area? as we know, this is the another part of the temporal bone, which is the petrous. So this is petrous apex. Now, this is second image of coronal cut, which is a bit posterior. So what we see here, what is this? This is stapes, right? This is malleus. This will be incus, right? And this is what I was talking about this spur. This is the spur of Causse or Chausse. We pronounce it as Chausse. Causse worked over autosclerosis. So don't confuse it with Causse. Causse is C-A-U-S-S-E. Causse. Causse worked mostly over the autosclerosis and stapes surgery. This is Chausse. So this is the spur. So what is this area? This is Prusak space. This is head of malleus. So if this is the stapes, then what should be this? This will be tympanic segment of the facial nerve. What is this? This will be superior semicircular canal. Again, this is tegment tympani, tegment mastoid, mastoid air cells, external auditory canal. What will be this? This is a coronal cut. So mostly below space will be hypotympanum. This is mesotympanum, this area. In between these two lines will be mesotympanum, this is epitympanum, and this will be hypotympanum, right? So what is this? This is vestibule. What is this? This is internal acoustic meatus. What is the bony ridge here? This is crista falciformis. So if you identify crista falciformis, again the examiner will ask you what are the structure that passes through the internal acoustic meatus. 7 up, coke down. Okay? So facial nerve will be above anterosuperior, antero-inferior will be cochlear nerve, and posteriorly, superiorly and inferiorly will be superior and inferior vestibular nerve. Singular nerve will enter through a separate canal, right? So now I am coming to the pathology. So this is a complication of acute otitis media, acute coalescent mastoiditis. What is that? If there is persistence or recurrence of symptoms like ear pain, ear discharge and fever, these three things, then we have to think about whether the patient is suffering from acute coalescent mastoiditis or not. What happens there? There is whole mastoid is filled with material and there is loss of trabeculae, that means septum in between the air cells. What you have to do? You have to answer that also. If you can identify, then you have to answer that we have to go for cortical mastoidectomy in this case. So now, this is a coronal cut. Here you can identify some pneumatized space with a perilesional enhancing. So this is a abscess. So this is below the level of the mastoid bone. So what abscess it could be? It is Basalt's abscess. At the same time, we are seeing here a filling defect. That means there is a thrombus inside a venous sinus. So this is sigmoid venous sinus. So sigmoid sinus thrombosis. There are two complications here. One is intracranial, another is extracranial, extratemporal. All right. Now let us see how a petrous lesion appears. In an axial cut, this is the axial cut where you can see there is a soft tissue destruction, but you also need a coronal cut. Why? Because here you can see that there is large area of destruction of the petrous apex area. To decide your further course of treatment, you need to read your CT scan. Now coming to this pars flaccida cholesteatoma. This is pars flaccida, this is pars tensa or mesotympanum. So this is pars flaccida, as I already told you, this is head of the malleus, this is handle of malleus, this is, you see here that the spar is lost and there is soft tissue lesion here. Alright, this is Prusak space. So this is displacing the ossicle medially, okay, and here you see that the ossicle is displaced anteriorly. There is this is epitympanum is alright, this is mesotympanum, and here the ossicle is lateralized. So this is a case of pars tensa cholesteatoma. This thing you have to remember, this is given in a table. What are the intensity that we see in T1 and T2 and diffuse and enhancement restrictions in MRI. So in cholesteatoma, granulation tissue, we get hypointense in T1 and hyperintense in T2. There is no enhancement in cholesteatoma, whether in granulation tissue there will be enhancement. Diffusion restrictions will be positive in cholesteatoma and granulation tissue will be no enhancement. What is cholesterol granuloma? Can anyone say what is cholesterol granuloma? How it forms? Is this related to cholesteatoma or not? So what it is related to? This is related to, this is a subtype of granulation tissue. Many students falter here. They say this is a part, this is a kind of cholesteatoma. No. How it forms? There is escape of blood from the marrow. I said in between the air spaces there are marrow, bone marrow. Some bone marrow, the blood escapes and drops into the air. Okay, in the air cell. And there it breaks down and it causes reaction. So it is a subtype of granulation tissue. So you have to sometimes differentiate it along with from the cholesteatoma. This is hyperintense in T1 weight and hyperintense in T2 also. But in diffusion restriction, this is variable. So in T1 weighted image, you have to differentiate it from the cholesteatoma and the granulation tissue. Both will be hypointense, whereas cholesterol granuloma will be hyperintense. Coming to MRI image. So MR image, this is a 15-year-old patient with a history of draining ear. So this is T2 weight, we don't see any enhancement. So what is this? This is cholesteatoma, right? This is cholesteatoma. Again T1, there is no enhancement. This is diffusion weight restricted image, which demonstrates the reduced diffusivity inside the lesion. So with this, I end my session. I'm handing over the mic to Sominda.
Thank you, Subhajit. Now, the examiner will ask you, now you have done these investigations, you have the reports with you. Now, what will you do? What are the options you have regarding treatment of this patient? That part will be taken care of by Professor Bibhas Adhikari.
My name is Professor Bibhas Adhikari. I am from CNMC. So, প্রথমেই বলো যে before go for examination of the ear, what will you do? You go for examination of the ear, what will you do? This is a dictum. What will you do? Oral toileting. Next, you go for investigation. Will start from UM, examination under microscope. Don't, this is a dictum. Why we do examination under microscope? Why we do? To confirm the diagnosis. আমরা otoscope করে যেটা দেখেছি সেটা কনফার্ম করলাম। সেকেন্ড হচ্ছে try to assess the extent of the disease. আমরা পুরোপুরি করতে না পারলেও আমরা চেষ্টা করব extent of the disease and nature of the disease and the oscular status. And third is thumb maneuver. Both hand is free, I can do suction clearance. Okay. Next come to the treatment. Next, management means investigation and treatment. Treatment means medical treatment and surgical treatment. Any medical, is there any medical treatment for squamous disease? তুমি বলো, এই তুই বল। No, there is always surgical treatment. So in case of squamous disease, there is no only surgical treatment. In case of mucosal disease, there is medical treatment and surgical treatment. Again, we do oral toilet and send the discharge for culture sensitivity. এটা দিয়ে আমি শুরু করব। সবসময় আমরা করি না, তাই তো? কিন্তু কী ধরনের অর্গানিজম থাকে? ইউজুয়ালি মিউকোজাল টাইপের স্টেপ্টোস্যাপাইলোনিউময় থাকে, কিন্তু যেই এটা মিক্স টাইপের হয়ে যাচ্ছে স্কোয়ামাস টাইপের, তখন অনেক বাগা অর্গানিজম চলে আসছে, যেমন সুডোমোনাস, প্রোটিয়াস, ইকোলাই, অ্যানারোবস, ব্যাকটেরিয়াস। একটার এক রকম ফাংশন, এক রকম গন্ধ। হ্যাঁ, সুডোমোনাসের একটা পচা গন্ধ ছাড়ে, প্রোটিয়াসের একটা ফিসি স্মেল হয়, অ্যানারোবসের একটা বাজে গন্ধ হয়, ব্যাকটেরিয়াস আর খতরনাক, রেসপন্সিবল ফর ব্রেন অ্যাবসিস। তো এইগুলো জানতে হবে। তো এই মতন আমরা অ্যান্টিবায়োটিক ট্রিটমেন্ট করবো। তো মেডিকেল ট্রিটমেন্ট উইল বি অ্যান্টিবায়োটিক। কী ধরনের অ্যান্টিবায়োটিক ব্যবহার করবো? আমরা ব্রড স্পেকট্রাম অ্যান্টিবায়োটিক ব্যবহার করবো। আমরা কালচার সেন্সিটিভিটির জন্য ওয়েট করি না। আমরা আর কি করবো? আমরা ড্রপ দেবো, ওরাল, ইয়ার ড্রপ দেবো। কি? অ্যান্টিবায়োটিক উইথ স্টেরয়েড। ইউ অল নো হোয়াই উইথ স্টেরয়েড, এটা নিশ্চয়ই বলতে হবে না আমরা স্টেরয়েড কেন ইউজ করছি। থার্ড হচ্ছে আমরা মিউকোলাইটিক, অ্যান্টিহিস্টামিনিক, ন্যাজাল ডিকনজেশন এগুলো দেবো। ঠিক আছে, দিস আর দ্য মেডিকেল ট্রিটমেন্ট। এর সম্বন্ধে বেশি বলছি না। আমরা কতদিন আমরা মেডিকেল ট্রিটমেন্ট করবো? আপ টু 3 months আমরা করে যাব, টিল দ্য পেশেন্ট। এইম অফ মেডিকেল ট্রিটমেন্ট ইজ টু মেক দ্য ইয়ার ড্রাই, নন ইনফেক্টিভ, ইনফেক্টিভ টু নন ইনফেক্টিভ, অ্যাক্টিভ টু ইনঅ্যাক্টিভ। তাহলে 3 মাসের মধ্যে যেই এটা ড্রাই হবে তখন আমরা পেশেন্টকে মোটিভেট করব কি অপারেশন করার জন্য। কী অপারেশন করব, কেন অপারেশন করব, পেশেন্টকে আমাকে মোটিভেট করতে হবে, তো পেশেন্ট তো পালাবে, তাহলে আমার কান ঠিক হয়ে গেছে। তা আমরা কেন মোটিভেট করব? তো তাহলে আমরা এই জন্য মোটিভেট করব যে বলবো যে তুমি তোমার রিকারেন্স অফ ডিসচার্জ হবে না। সেকেন্ড হচ্ছে তোমার হেয়ারিং ইমপ্রুভমেন্ট হবে। থার্ড হচ্ছে তুমি মেডিকেলি আনফিট, তুমি পুলিশে চাকরি নিতে গেলে, আর্মিতে চাকরি নিতে গেলে তোমাকে নেবে না, তাড়িয়ে দেবে। তাছাড়া কিছু প্রফেশনাল দোজ হু গোজ টু দ্য ওয়াটার, যেমন সুইমার, স্কুবা ডাইভার, এদের জন্য আমরা বলবো এদেরকে মোটিভেট করবো তোমরা অপারেশন করো। কী অপারেশন করবো না, টিম্প্যানোপ্লাস্টি করবো। টিম্প্যানোপ্লাস্টি, সিম্পল টিম্প্যানোপ্লাস্টি। টিম্প্যানোপ্লাস্টি অনেকগুলো টাইপ আছে, টাইপ 1, টাইপ 2, টাইপ 3, অল ইউ নোজ। টাইপ 4 অ্যান্ড টাইপ 5 আমরা করি না, ওইসব পেনেস্ট্রেশন, সোনো ইনভার্সন সব আমরা করি না, তাই এগুলো আমি বলছি না। তাহলে আমরা সিম্পল মেডিকেল ট্রিটমেন্ট করব, মেডিকেল ট্রিটমেন্ট ফলোড বাই টিম্প্যানোপ্লাস্টি। তাহলে তুমি কোশ্চেন জিজ্ঞেস করো স্যার কখন আমরা অসিকুলোপ্লাস্টি করব? আমরা আসছি অসিকুলোপ্লাস্টি। এবার রিগার্ডিং ট্রিটমেন্ট অফ স্কোমাজাল ডিজিজ। স্কোমাজাল ডিজিজ অ্যাটিক পারফোরেশন বা অ্যাটিকোয়েন্টাল ডিজিজ, দের অ্যাটিক পারফোরেশন, পসিওসুবিয়ার মার্জিনাল পারফোরেশন, দের ইজ কোলেস্টিয়াটোমা, গ্র্যানুলেশন, অনেক কিছু আছে। তা আমরা প্রি অপারেটিভ আমরা HRCT করে নিয়ে দেখে নিয়েছি, এক্সটেন্ট অফ দ্য ডিজিজ অ্যান্ড অসিকুলার স্ট্যাটাস। এবার পেশেন্টকে আমরা অ্যাডমিশন করব, করে আমরা অপারেশনের জন্য প্ল্যান করব। কী অপারেশন করব? কখনোই তোমরা পরীক্ষায় বলবে না যে স্যার আমি ম্যাস্টেক্টমি করব, মডিফাইড রেডিক্যাল করব। বলবো স্যার আমরা উইল গো বাই পোস্টোরাল রুট। তুমি এন্ডোরাল জানো, কিন্তু তবুও বলবে পোস্টোরাল রুট বাই গিভিং পোস্টোরাল ইনসিশন, lift up the tympanomeatal flap, expose the attic region. Again I will try to assess the nature and extent of disease and the ossicular status. খুব ভালো বোঝা যাবে না আমরা, then I will do অ্যাটিকোটমি। অ্যাটিকোটমি করলে আমরা অনেকখানি বুঝতে পারবো যে আমরা এক্সটেন্ট অফ ডিজিজ, নেচার অফ ডিজিজ, অসিকুলার স্ট্যাটাস কি। সেই মতন দেন উইল টেক the decision of whether we will do aticotomy only or acute-antostomy or modified radical or radical according to extent of the disease. Okay, all are canal down procedure. তোমরা অনেক সময় ক্যানাল ডাউন, ক্যানাল আপ এগুলো বলো, এগুলো বলার দরকার নেই। প্রথমে অ্যাটিকোটমি, অ্যাটিকোট-অ্যান্টোস্টমি, মডিফাইড রেডিকুলার ম্যাস্টেক্টমি আর ম্যাস্টেক্টমি, অল আর ক্যানাল ডাউন প্রসিডিওর। আগে আমরা অ্যাটিকোটমিকে ক্যানাল ডাউন বলতাম না, কিন্তু এখন সাম্যতে বলছে অ্যাটিকোটমি অলসো ক্যানাল ডাউন প্রসিডিওর। ক্লিয়ার? গট ইট? তাহলে ক্যানাল আপ প্রসিডিওর কোনগুলো? ক্যানাল আপ প্রসিডিওর যেমন হবে যেখানে কর্টিক্যাল ম্যাস্টেক্টমি করছি, ডিজিজ ক্লিয়ারেন্স ফ্রম দ্য কর্টেক্স, অ্যান্ড আমরা টিম্প্যানোপ্লাস্টি করছি, লিভিং বিহাইন্ড আমরা পশ্চিমীয় ক্যানাল ওয়ালটাকে ইনট্যাক্ট রাখছি, দ্যাট ইজ ক্যানাল আপ প্রসিডিওর। যেমন কম্বাইন্ড অ্যাপ্রোচ টিম্প্যানোপ্লাস্টি, আমরা কর্টিক্যাল ম্যাস্টেক্টমি করছি, উই আর ডুইং কর্টিক্যাল ম্যাস্টেক্টমি অ্যান্ড টিম্প্যানোপ্লাস্টি, ক্যাট অ্যান্ড পশ্চিমীয় টিম্প্যানোটমি, হোয়ার উই ডু কর্টিক্যাল ম্যাস্টেক্টমি অ্যান্ড ফেসিয়াল রিসেস অ্যাপ্রোচ to clear the disease from the to clear the disease from the posterior mesotympanum or ectotympanum. তাহলে what are the canal up procedure or canal down procedure বোঝা গেল? Canal down procedure is the atticotomy, when removing the outer attic wall or scutum, then entering into the antrum, removing the most of the part of the posterior superior canal wall, this is attico-antostomy. When you are removing the both whole of the posterior superior canal wall from anterior vertex to posterior vertex, that is the radical mastectomy. And what is modified radical mastectomy? Radical mastectomy means anything less than radical mastectomy is modified mastectomy. আমি যদি মনে করি যে না পেশেন্ট ইয়াং, পেশেন্ট রিজার্ভ হেয়ারিং ফর ফিউচার অসিকুলোপ্লাস্টি, তখন আমি ইফ দেয়ার ইজ এনি পার্ট অফ দ্য মিডিলিয়ার ক্লেফট ইজ নট ডিজিজড, সে যে হেপি সুপারস্ট্রাকচার অর সাম পার্ট অফ দ্য টিম্প্যানিক মেমব্রেন অর পেশেন্ট নিড নট নো নিড ফর ক্যানাল ডাউন, তাকে আমরা মডিফাইড র্যাডিক্যাল বলবো। এনিথিং লেস দ্যান র্যাডিক্যাল ইজ মডিফাইড র্যাডিক্যাল। তাই হোয়াট ইজ র্যাডিক্যাল ম্যাস্টেক্টমি? ইফ আই আস্ক give me the definition, বলো তুমি বলো, তুই বল, হোয়াট ইজ র্যাডিক্যাল ম্যাস্টেক্টমি? ঠিক আছে, ওকে। It is a procedure. It is a procedure where all the disease tissue is removed from the medullary cavity, attic, adytus, and antrum, and the two cavity turn into a single communicable, disease-free, socialized cavity by lowering down the posterior superior canal wall. তাই এই ডেফিনেশনটা বলতে হবে। এর সঙ্গে আমরা আরেকটা operation kori, that is myotoplasty. Myotoplasty, why we do myotoplasty? That is that the external auditory meatus is widening. That is myotoplasty. But only myotoplasty, if you do only myotoplasty, there will be chance of stenosis. Then we will do conchomyotoplasty. That is wide for drainage purpose, to prevent bottleneck effect. If there is collection inside the mastoid cavity, ota jodi come out, that's why we do conchomyotoplasty. But now comes to the অসিকুলোপ্লাস্টি। অসিকুলোপ্লাস্টি কখন আমরা করব? অসিকুলোপ্লাস্টি তো বুঝতে গেলে তোমাদেরকে অস্টিন ক্লাসিফিকেশনটা জানতে হবে। অস্টিন ক্লাসিফিকেশন হচ্ছে A B C D, সবাই জানো তো? তা তোমাদের যদি জানো তো, কে জানে? কেউ বলো একজন, হোয়াট ইজ অস্টিন ক্লাসিফিকেশন? অস্টিন কার্টুস ক্লাসিফিকেশন, অস্টিন কার্টুস ক্লাসিফিকেশন কে বলতে পারবে? কে? হ্যাঁ বলো।
Type A, malleus and stapes suprastructure is present. Type B, malleus present, stapes not present. Type C, malleus absent, stapes present. And type D, malleus and stapes absent.
আচ্ছা, ওকে, ঠিক আছে। তাহলে অ্যাকর্ডিং টু দ্য অসিকুলার নেক্রোসিস, আমি both squamous and mucosa, in both positions there is ossicular necrosis according to Austin classification. তাহলে আমরা কি করব? পেশেন্ট ইয়াং এজ, তার হেয়ারিং দরকার, তার স্কোয়ামাজাল টাইপ অফ এক্সটেন্সিভ ডিজিজ, আমি ডিজিজ রিমুভ করলাম, কিন্তু আমি হেয়ারিংটাকে কিছুটা আমি যদি ব্যাক করে দিতে পারি, তাহলে আমি অসিকুলোপ্লাস্টি করব। তাহলে কমনেস অসিকুলোপ্লাস্টি কি? যেমন অস্টিন এ টাইপ অফ যে ডিফেক্ট, যেখানে ইনকাস নেই, ইনকাসটাকে আমি বের করে নিয়ে রিশেপ করে বা স্কাল্পচার করে আমরা ইন বিটুইন দ্য ম্যালিয়াস অ্যান্ড সেপিস সুপারস্ট্রাকচারের উপর বসিয়ে দিতে পারি। তাতে কিছুটা হিয়ারিং গেন ইমপ্রুভ হবে। জল লাগতো, জল দাও, এত গলা শুকিয়ে যাচ্ছে, এত এত চেঁচাচ্ছি। ওইখানে আছে তো, একটু দে না, তাদের দে। তাহলে কমনেস্ট টাইপ অফ অসিকুলোপ্লাস্টি হচ্ছে ম্যালিয়াস ট্রাপিজিয়াস স্টার্ট, তাই তো? এবার আমরা কি জিনিস ব্যবহার করছি? আমরা ইনকাসটাকে ডিসেপ করে দিতে পারি, আমরা কর্টিক্যাল বোন নিয়ে আমরা তৈরি করতে পারি, আর প্রসেস ইউজ করতে পারি, ঠিক আছে? নেক্সট কমন, তাহলে আমরা কি অস্টিন ক্লাসিফাই নেক্সট কমন আমরা অসিকুলোপ্লাস্টি কী করি? আমরা পর্ব দিই, যেখানে ম্যালিয়াস ইনকাস নেই, অনলি সেপি সুপারস্ট্রাকচার ইজ দেয়ার, আমরা একটা পর্ব বসিয়ে দিতে পারি। যেখানে অস্টিন ডি টাইপ, যেটা শুধু ফুট প্লেট রয়েছে, সেখানে আমি টর্ব বসাতে পারি। বোঝা গেল? ক্লিয়ার হয়ে গেল তো? তাহলে এইগুলো অসিকুলোপ্লাস্টি, এগুলো একটু পড়ে নেবে। তাহলে একটু যদি পরীক্ষা জিজ্ঞেস করে যে হোয়াট ইজ সাকসেস রেট অফ টিম্প্যানোপ্লাস্টি, তোমরা অলওয়েজ সে 85%। যে যা বলছি, কেউ 95% বলতে পারে, বলুন, তোমরা 85% বলবে। এবার অসিকুলোপ্লাস্টির সাকসেস রেট কি? অনলি 55 to 60%। কিন্তু বাট তুমি যদি সাকসেসফুল অসিকুলোপ্লাস্টি করো, ইফ দ্য প্রস্থেসিস টেকেন আপ, তাহলে হেয়ারিং গেইন ইজ মোর দ্যান দ্য টাইপ 1 টিম্প্যানোপ্লাস্টি। বোঝা গেল? তাহলে আমার ট্রিটমেন্ট প্রোটোকল আমি কিছুটা বোঝাতে পেরেছি, ঠিক আছে? থ্যাংক ইউ। এই ঠিক আছে, বুঝেছিস? তোরা বুঝেছিস সব? হ্যাঁ, সহজভাবে বলার চেষ্টা করেছি একটু। আর ওইটা মনে রাখবি, পরীক্ষার সময় যদি জিজ্ঞেস করে, প্রত্যেক এক্সামিনার লাস্টে বলে, এই তুমি কী করবে বলো, এই বলো কী করবে বলো, এই তোমার এই কেসে কী করবে বলো। স্যার ম্যাস্টেক্টমি, স্যার মডিফাইড, স্যার কর্টিক্যাল টিম্প্যানো, এইভাবে বলবে না। আবার আমি বলে দিচ্ছি, স্যার আই উইল গিভ postural incision, I will go by postural approach, by giving postural incision, lift up the tympanomeatal flap, expose the attic, then I see the nature and extent of the disease and ossicular status. সেটা ভালো করে বোঝা যাবে না। Then I will do articulotomy, again I will reassess the nature of the disease and ossicular status. Then I will take the decision whether only aticoantostomy will do, aticoantostomy, articuloplasty, or modified radical mastectomy or radical mastectomy according to extent of the disease. ঠিক আছে? এইভাবে আমরা অপারেশনটা করব। এর সঙ্গে আমরা কনকোমিওপ্লাস্টি করে দেবো ফর ড্রেনেজ পারপাস।
So now Dr. Arindam Das will carry forward with the surgical treatment for chronic otitis media squamous disease. Now you have the best option to clear your doubts and also learn about surgeries from Dr. Das. So if you have any doubts, feel free to ask your questions. Dr. Das.
Hello. Good morning, everybody. Lot of comprehensive discussion already has been done on COM, history taking, treatment, everything. Treatment is sometimes very confusing, contradictory, and during your examination with the examiner, everybody have a different type of perception of ear surgery. In every institute or every hospitals, you do your surgeries in your PG shifts. So you have already done lot of mastoidectomy with different techniques. Sometime inside out, outside in, canal wall up, canal down. A lot of terminology has been used. But for this case provisional diagnosis. Okay. So in this case, suppose in a examination setting, this case has been given. So this is a active squamosal disease. That means this is a cholesteatoma. Okay. If this is an inactive squamous cell disease, then it will be a retraction pocket. So somehow treatment will be mastoidectomy, but there are some differences. So when you will answer the case, so what is your treatment? So there are medical treatment, surgical treatment, and what is the surgery you will do? Anybody? Please answer anybody. So what will be your answer? So what surgery you will do for this case? Is a cholesteatoma? Mic down now. Anybody? Please answer. Bolo? So I am not the examiner. We are not giving any questions or number.
Mastoidectomy plus with or without with or without tympanoplasty, with or without osculoplasty, depending on the
So
status.
its better terminology is mastoid exploration. So we will explore the mastoid according to the extension of disease. We will decide our surgery or the nature of surgery. And second point, the most important point is what is the goal of your surgery? Previously, it was just make the ear dry or make the ear safe, but now we have two other things to do. First is make the ear safe, complete disease clearance. So as it is a cholesteatoma, that means it is a destructive disease to the middle ear and associated anatomical structure. So we have to completely remove the disease. Second thing, we have to make the ear dry, and third most important in today's era is hearing reconstruction. So these three are the goal for the treatment or surgical management. First is complete disease removal, second is make the ear dry, because after mastoidectomy surgery there are so many cavity problems are there that leads to a chronic discharging cavity. So we have to prevent this complication, and how will we prevent, that we will discuss in the surgery section. So first these three are our goals. Now for this cholesteatoma, what kind of surgery you will do ultimately? So the whole mastoidectomy surgery has been divided on the canal wall. Okay. So there are two types of surgery. One is canal wall up surgery and one is canal wall down surgery. So for cholesteatoma, with or without complication, most of the time we go with the canal wall down surgery. Why? Canal wall up is also an option for cholesteatoma, but the disease should be limited, and there are some important factors like in canal wall up surgery there will be 20 to 25% recurrence of cholesteatoma in long term, 20 to 25%. This is a very high percentage of recurrence. Even we need a second look surgery after 12 months if we go with canal wall up surgery. Okay. So for cholesteatoma, if we are planning for canal wall up surgery for any reasons or surgical expertise, then second look surgery is important and necessary after 12 months or after 1 year. Second look surgery can be avoided by a investigation. What is the investigation? Yes, already Gonzalez described diffusion weighted DWMRI non-EPI. So it can detect the cholesteatoma very easily. So if there is any recurrence of cholesteatoma after canal wall up surgery, then we can go with the DW weighted MRI so that we can detect if there is any recurrence of disease or not. Then second look surgery can be done. So now come to the canal wall down surgery. Two types conventionally. So whatever you have done in your PGC for this time being, for this 1 or 2 months, forget everything, just stick to the principle and discuss on the basis of the principle. So one is modified radical mastoidectomy and one is radical mastoidectomy. So modified radical mastoidectomy, there is reconstruction, maintenance of the mesotympanic cavity or aerated middle ear space. In case of radical mastoidectomy, we have to close the eustachian tube, we have to remove all the structures from the middle ear space except footplate of stapes because that covers the inner ear. So we don't want the infection will go into the inner ear and ultimately the residual hearing will be lost. So except the footplate of the stapes, everything should be removed, all mucosa should be removed, we have to plug in the eustachian tube. So that is the radical mastoidectomy, and you have to remember the indication for radical mastoidectomy also. What are the indication, anybody, for radical mastoidectomy? এইগুলোই পরীক্ষায় জিজ্ঞেস করে পরপর যখন হচ্ছে যে স্টেজড হয় কি কি অপশনস করবে, কি কি ট্রিটমেন্ট করবে এবং তারপরে সেই ট্রিটমেন্টটা করতে গেলে কি কি প্রবলেম হতে পারে। ওকে, সো হোয়াট আর দ্য ইন্ডিকেশন অফ র্যাডিক্যাল ম্যাস্টোডেক্টমি? বলো বলো, ইন্টারঅ্যাক্টিভ না করলে হবে না, আমি কতগুলো কথা বলে যাব, সারা বছর 3 বছর ধরে এগুলোই শুনে আসছিস তোরা। র্যাডিক্যাল ম্যাস্টোডেক্টমি কি কি?
Anyone?
Unresectable cholesteatoma extending into the petrous apex.
Very good.
It is extending into the eustachian tube or pedilabinterna or hypotympanum, tympanic bone neoplasm. Radical.
Good, already discussed. Okay, and if the cholesteatoma sac entered into the cochlea leading to
fistula,
promontory fistula with a SN loss, or if there is no chance of hearing reconstruction, then it is better to go with canal wall down radical mastoidectomy. Okay, so okay, thank you. So these are the indication for radical mastoidectomy. So most of the time for your case we have to go for the mastoid exploration. There are 2 types of surgery, outside in. First we to do the cortical mastoidectomy, then follow the disease anteriorly to the epitympanum and resect all the disease from the middle ear and mastoid cavity down the external auditory canal up to the lateral semicircular canal. Okay, and then this will be the mastoid cavity. Now removal of the disease and canal wall down mastoidectomy, is it sufficient to prevent all the mastoid related complication in the postoperative phase? No. So we have to make the ear dry. So to make the dry ear, we have to take something during surgery. What are the things? Well suturation cavity, complete removal of the disease and mastoid obliteration. Okay, so this is a very important part for your examination, is the mastoid obliteration. So obliteration are also of 2 types, complete obliteration and partial obliteration. What is complete obliteration? In case of subtotal petrosectomy, malignancy, blind sac closure, we have to put fat or any soft tissue inside the middle ear and cover all the middle ear space. That is the complete obliteration. For our CUM surgery, day to day basis, we have to do partial obliteration. We have to minimize the mastoid cavity. The volume of the mastoid cavity should be minimized in the postoperative phase to improve the hearing of the patient and to reduce the postoperative cavity problem or the discharge. Okay, so ki bhabe kora jay? What are the steps for mastoid obliteration? What are the techniques? What are the things can be used for mastoid obliteration? Bolo, everybody you have done. Palvas flap, very commonly used, musculoperiosteal flap. Second, bone patty from the same patient. We have to collect the bone dust during our cortical or the initial phase of mastoidectomy, then use this bone patty either directly, or we can use a tissue glue to adhere inside the mastoid cavity. So, bone patty. Second, next, cartilage. Cartilage perichondrium composite part can be used for mastoid obliteration. Okay. So, these are the things, even bioglass and the artificial things can be used, but their use is very much restricted in our practical practices. So, we always use the cartilage, bone patty, everything to reduce the mastoid cavity. And each and every cases of modified radical mastoidectomy, we have to give a graft over the tympanic membrane or the medullary cavity. So, this graft will facilitate well epithelialized mastoid cavity. So, epithelialization will be proper. So, there will be sometime this question will be asked in a case of cholesteatoma after a canal wall down mastoidectomy, whether you will put a graft or not. So, definitely in a case of modified radical mastoidectomy, we will put a graft. So, it will reconstruct the neotympanum, increase the hearing result, as well as well epithelialized mastoid cavity can be formed over this tympanomeatal graft or flap. Okay. So, these are the basic two parts of mastoidectomy. You have to remember the indication, contraindication of canal wall down, canal wall up mastoidectomy and the process. Third, the last part, this is a era of minimally invasive surgery. So, without discussing endoscopic surgery in a case of ear disease, that is not okay. So, endoscopic mastoidectomy is also a option for limited disease. If there is a limited disease confined to the epitympanum or the attic region, not crossing the lateral semicircular canal, endoscopic atticotomy or endoscopic mastoidectomy will be also a option. So, first is the canal wall up, canal wall down, and third is the endoscopic mastoidectomy. So, it gives better control of the cavity as well as the hearing result in the postoperative period. Okay. So, these are the overview of mastoidectomy or the surgical context. Now, the complication, a whole chapter is the complication of COM. So, you have to read each and every complication, but day by day the complication rates are decreasing due to early intervention to the patient. So, nowadays as a faculty or as a student, you also do not get a large number of cases of complication like meningitis, brain abscess in your tenure. But previously it was seen a large number of complicated COM we used to treat. But due to early intervention, the complications are day by day reducing. But still we get some meningitis, subperiosteal abscess like Bejold's abscess, everything, extracranial complication, intracranial complication, everything. So, read this chapter, the complication. Most commonly asked in context to the COM surgery is the facial paralysis, vestibulitis or lateral canal fistula, and these abscesses, say periosteal, subperiosteal abscess, Bejold's abscess, Sitley's abscess, etc. Okay. So, these are the treatment options and the mastoidectomy discussions. Now, if you have any questions on the mastoidectomy or this surgery in context to that, you can ask, we can answer to this question. I think is kono question ache, please. Okay, outside in and inside out. So, inside out you are doing first the atticotomy, okay, drilling of the scutum and the lateral attic wall, then you will go posteriorly through adductus into the antrum, and according to the disease extension you will saucerize the cavity. So, it leads to a smaller cavity according to the principle. And outside in is the conventional approach. First you have to do a cortical mastoidectomy check whether the cholesteatoma reaches to the mastoid antrum or the tip cell, etc. Then you will go anteriorly, drill the epitympanum, and then finally remove the canal wall to do a canal wall down. 2 or 3 important things that should be taken into consideration is the radiology to differentiate. Already Gonzalez discussed, if there is a very contracted mastoid antrum, antepost sigmoid sinus, residual disease is inside the epitympanic cavity, then inside out will be a better approach rather than doing a cortical mastoidectomy in this setup. Okay. So, radiology is a factor that can differentiate whether you should go with a inside out or outside in. And second important factor is your practice, institutional practice. Some surgeons prefer inside out approach, some surgeons prefer outside in approach. The result is same if you adhere to the principles of the mastoid surgery. Okay. Bolo. Inactive squamosal cell disease, that means retraction pocket. Okay.
So, as in there is a scenario like there is a patient who has got a grade 2 retraction of the pars flaccida and it is self cleaning and there is
Yes.
no discharge,
So-
and there is ossicular necrosis with grade 4 retraction of the pars tensa. So in that case, sir, what do we do?
For retraction pocket means inactive squamous cell disease, if the pocket is self cleansing, means grade 1 or 2, if it is a self cleansing, then regular follow up will be an option. Okay. Second part is definitely inside out mastoidectomy. Definitely inside out mastoidectomy, as this is a limited disease, retraction pocket, you will not do a cortical mastoidectomy, you will not get anything inside the mastoid cavity, because the disease start into the mesotympanum by the negative pressure and it will be retraction. So, first you have to do a inside out mastoidectomy. According to the ossicular status, you have to do the ossiculoplasty for the setup. Suppose you have a pars flaccida retraction type 2 with a ossicular chain incus necrosis. In this setup, what you will do? You will do inside out adichotomy. You will remove the scutum, remove the retraction pocket, then do a proper ossiculoplasty. That can be a TORP or any other cartilage ossiculoplasty you can do. That can be a columella or interposition contraplasty. Yes, there is already a question was there is a Marquette procedure, I think. There is a excision of the sac and insertion of the grommet into the anterior inferior quadrant. So, definitely that is the option, but in our day to day practice, we do not put a grommet in cases of inactive mucosal disease, we just remove, because grommet insertion will not change the whole scenario, because this is a eustachian tube or ventilation fold disorder. Okay. So, if you treat the attic or the ventilation fold, most of the time the disease settles. Yes, sir. Definitely retraction pocket, reinforcement of the tympanic membrane, you can use a cartilage grafting for that, and slice thickness should be less than 0.5 millimeter. Okay. So, very thin slice cartilage should be put to reconstruct the tympanic membrane, and that will enforce and prevent future retraction in that patient. Sir.
For
please.
collection of the bone patty, what precaution you will take?
Say bone patty. Say bone patty, we can use the antibiotic solution with that. Second, in a bone patty, in our practical and as well as in a literature says, there is a chance of infection. If there is a infection into the bone patty in the post-operative phase, this is a very notorious thing. Okay. And during this surgery, the bone patty, when you are collecting, that should not be contaminated with any infected tissue like cholesteatoma or in a case of retraction pocket or squamous epithelium. So, only lateral part of the bone you should harvest. When you are going deeper inside the cavity, you should not harvest the bone from that part. Yes, sir. Thank you, sir.
And if you have any further doubt, you can always submit your questions to us. We will discuss tomorrow in the second half. So, regarding your query that grommet, you should assess individual patients. In this case, it is a global disventilation, but in most of the cases there is selective attic disventilation. So, if there is selective attic disventilation, by ventilating the mesotympanum you gain nothing. So, depending upon the cause of this retraction pocket, we should tailor our treatment. Now, before we go to the last and the most important part, I must say that we do our best for each disease. We try to give the best results, but all the patients and all the disease do not behave similarly. So, there is a need for prolonged follow-up, and also you should discuss with the patients the prognosis may differ. So the last session will be by Colonel Ajoy Mollik, and before we go to the last session, I must thank Tonoya. Tonoya is here. This PowerPoint presentation, this case discussion has been prepared by Tonoya meticulously. So I will hand over the microphone to Colonel Mollik.
Thank you. So good afternoon. We come to the last part, not the last, but it is a continuum, because as you know, COM, squamous disease in this case is not an open and shut case. It continues, right? And sometimes this is the most important part which decides. You may do a beautiful surgery, you may do a fantastic ossiculoplasty, but your assistant goes and puts a nice high powered, high pressure suction, and he takes out the graft or dislodges the things, right? It happens very common. And if you do not take the post-op care, the chances of infection and your whole beautiful surgery goes for a 6, right? So we will try and cover up some of the points which are very common. And so what are the post-op care which you would like to do in the immediate post-op? Anybody? Any takers? Mike, quick, because we don't have time. Give it, yeah.
Avoid contact with water. Avoid contact with water.
Excellent.
And that is dry air precautions. And if there is sneezing or coughing, then avoid the effortful, with open mouth only they should.
Okay. See, what you must do, I'll tell you what is. Medicine is not rote learning. You have to understand certain things and put it, you saw that chart, chronological order, just put it in your mind. What are the structures which you have touched, or what are the structures which you have damaged? One is the middle ear. This little bit can be, you have moved the stapes a bit while doing ossiculoplasty, so there can be a bit of what you do after stapedectomy is little bit of vertigo. So the care of the patient has to include those kind of symptoms also, right? So the common things we do, let us keep the ear dry, put a mastoid bandage, let the patient be there, pain management and all that. But you must keep these minor and things which can really affect the patient. If the patient has vertigo and falls down, right, you can have further complications. So we will quickly go through this. The slides will be given to you. Just note it down. Just look. No need to waste your time on writing. We do a ear packing, which is generally we keep it, depending on the material we use, we keep it to 1 to 3 weeks. If you are using a bib PAP, you can keep it for 3 weeks. Pain management, antibiotic, ear protection, which he said beautiful. That is the most important actually. Keep the ear dry. And you have restricted activities like avoid bending and all those things, right? So these are the 4-5 things. If you use your imagination, you will all of them be able to tell this in your mind. Just keep your mind open in the exam. That is most important. Okay. The second visit, this is after the first follow-up. That is immediate post-op. Now the patient is going to be on discharge after a week. What are the instructions you are going to write in the post-op? So that will come, and the patient comes and you remove the pack and then you inspect the ear. Don't try to be too heroic to remove everything that time, right? Don't try to be too heroic at that moment or time, and just a basic kind of cleaning. In the subsequent follow-up, you look for now how good or how bad is the healing process. You can remove now this should be done slightly by an experienced person, and you all are experienced. Don't leave it to your first year, the first cleaning. Right, the first cleaning, don't leave it to your first years. Do and remove the crusts and the drainage which you are seeing, and that is the time you start putting all the antibiotic ear drops, and if watch now for any symptoms of any hearing loss, and all. Hearing loss will be there, but dizziness, pain and all that. So now we move on to the slightly more, once the hearing healing is more advanced, this is the time you go and do a hearing test. Do not do the hearing test before 3 months. The patient will say, oh, my hearing, you say no, it is after, and this is a pre-op counseling. One thing we missed in this, in this crammed up thing is the pre-op counseling. Pre-op counseling for a COM, squamous disease patient is very, very important. You have to counsel the patient about what are the problems which the patient is going to have normally. There is going to be ear discharge after the surgery, right? There is going to be a bit of hearing loss. There is going to be repeated visits. So if you don't counsel them, you will end up in problem later on. So you have to keep the counseling and the communication open before you even go in for surgery. And then you have the follow-up, which is furthermore, which is more on now to see what are the long-term complications. Have you left a disease behind? We just saw 20 to 25% disease can be there in an endoscopic, and in a new surgeon you can have that kind of complications, right? So now we come to such general tips are therefore signs to report. These are to be written in your case notes. Today is an era of litigation. Please remember that you have to protect yourself also. So, make a template and give it to the patient in the language the patient knows. If it's a Hindi person, please give it Hindi, Bengali, English. Just make it and just hand over that thing to the patient. It's already written here, you know it, fever, pain, redness, discharge, anything, please report immediately, right? Make sure that you give this kind of paper with the case notes, okay? Avoid the trauma and ear cleaning, follow the instructions as told to you. Write this line, you are covered up legally, okay? Put the onus back onto the patient if something goes wrong. And this, remember, all these protocols will depend on the type of surgery you have done. If it is endoscopic, some things will be less. If it is the kind of we have gone in for a modified radical mastectomy, post-oral route most likely. So that means your surgery, and different institutes follow different protocols. Correct? So I think this is something which you all know, but get in the habit, look in the mirror and just speak about it once. The 6 points, just in the mirror in front of you, just say these are the 6 points. You are prepared for the exam. Correct? Now, when do you consider second stage surgery? You have done MRM, you have done a beautiful cavity. When will you consider, oh, I have to go in again? If there is a cholesteatoma Pearl 1, think.
Any complication,
very good.
post-operative complication,
Very
like
good.
giddiness.
You are finding a
tinnitus.
certain kind of, we have just discussed some of the complications, right? So, these are the, tell.
In case of recurrence or recidivism, we'll go, in case of recurrence or recidivism, we'll go for next.
That's, she's meaning that. So, also, you can go in, one is we only thought about the bad. If there is a complication, if something, sometimes you have to go in as a part of the management. So, this is a part of pre-operative counseling. This is a 2 or more stage surgery, right? Nowadays, once you get experience and you are sure about a disease and all those things, you can go in for a 1 stage. But at your level, you should in the exam say it is a 2-stage surgery, right? You will be more safer. Why? We go with the positive parts, reconstruction the eardrum, say there is a perforation or normal part, we have to go in for that. You have a treatment of any residual cholesteatoma already beautifully covered up. Hearing restoration, sometimes, the older teaching was avoid hearing in the first, go in for a second stage. So some people follow that is institution protocol. You find you are not very sure, there were a lot of granulations there, you are not very sure whether you have removed everything. Don't try to be heroic in the first go, right? And the fourth, we have a delayed reconstruction of the mastoid cavity. You are sure after a year it is all okay, everything is nice, the ear is discharged. Maybe now, today's world, you can go in and then reconstruct, especially if it is a girl, young patient, you can go and reconstruct this cavity over there, right? Once you are very sure that the disease is silent. And the timing is again, as I said, a second stage is generally everything okay, you go in not before 6 months. If you have a cholesterol clearance, please do it early. You have a clear, sure shot cholesteatoma you are seeing, go in early. Otherwise, you go in about 12 months. And if it is adequate healing and all that, and there is no infection, then you can proceed for the reconstruction surgery. Clear? Last benches? Now we come to the thing of cavity. It's a huge problem in a modified radical mastectomy. The cavity care is an ongoing process. We just told you that. So maintaining the cavity requires a lot of visits to the patient. So what do you do? How long should a pack last? Generally, how much of the time would we keep? 3 weeks, 2 to 3 weeks, depending on what material you have used, right? Then the healing process, the goal of the earring process is to reduce the chance. Why do you pack the ear? Why do you pack the ear? To keep the healing process intact and maintain the contour of the, you have done a beautiful canaloplasty, so you have to keep that contour a bit open. So what you do, initial 1 or 2 days, you keep it over there. Once the pack is removed, you have to do home care, that is clean the ear, keep the cavity dry and avoid water to be going in the ear, right? So now, a lot of the times when I ask the the students, how will you keep the ear dry? They say no pond bathing. That is the answer I get. Sir, no pond bathing. How will you keep the ear dry? Sir, no pond bathing. So I said, how is the patient now going to have a bath? The cotton ear plug, the students are not able to tell. Right? So many times I have gone to, especially all these, and not only in West Bengal, outside. So you have to tell the patient in the practical mode. Kanta Shukirako is not the answer. He will not know. He bathes in the pond, my dear. He's got no bathroom. He doesn't have a jacuzzi. I think you have done it. So you have to tell him the exact thing. Please put a oil packed ear and put it over there, and then, or you put a plastic cap and then you have a bath. Okay. So be practical in what you are telling the patient. That is very important. Home care, nowadays you can push nothing else. Tell him to make salt water 0.9%, very simple. You can make it in the home also with boiled water and do it. Doesn't have to go and buy in the market. Keep the cavity here and avoid exposure. Now what are the materials commonly used? What are the materials commonly used? What do you all commonly? What do you use? Pack the ear. Gel foam only plus ribbon gauze, antibiotic soap, okay, in liquid paraffin or some Vaseline, that is a common one. But when you are writing a theory paper, you have to tell everything which is known to you, right? So we come to certain things like Surgicel. Surgicel also is there in base of gel form. Cotton packing is the most common thing, ribbon gauze. You have silicone and these hydrocolloid dressings which are coming nowadays. They are synthetic materials or semi-synthetic materials which are malleable. It just fits into the cavity and very easy to remove and very less chances of infection, but they are expensive. Okay. So this covers the complete list of materials which are commonly used. I have not used the addition, that is antibiotics and all that. So plus remember what happens if you forget about the pack. So these are certain potential complications which can occur, which are infection, granulation tissue and obstruction to the drainage pathway. Clear? Granulation tissue is a very big issue in post-operative mastoid surgery. Follow up again is then regular checkups, and the surgeon's roles is to clean this, and the patient, as we have showed, is about this. Now, how do you know a complication has occurred? What are the signs of the complication? We told in one of the previous slides to tell the patient, if you have this, you must come back. So I am repeating that: fever, redness, pain, swelling and unusual discharge. There will be normal discharge, please remember. But if you are getting a mucoid discharge, bit careful. Mucoid discharge comes from the middle ear, right? So you are having some kind of a perforation or a granulation tissue, and immediately report to the doctor after this. So preventing cholesteatomia recurrence is, watch for recurrence is if the cavity is to be kept clean, as already mentioned, you can go over CT scan or a T2 weighted MRI, DW weighted MRI and regular cleaning. We have emphasized this, right? So I think we have covered the complete spectrum of a COM case. All of you are going to get a long case in COM, right? So we'll have the questions later on. So last, I'll give one small trivia to you. Okay, we'll light-hearted now. You've been, jam-packed with an AK-47 machine gun, automatic blast, for I think 1.5 hours. So certain questions. Who performed the first mastectomy? Anybody? Schwartz. Not bad. Not bad. Schwartz is there, but Ambrose Paré, 16th century, imagine. But after that, there were so many complications, so, it went out of thing. Toynbee's in this disease was the first work was described and one of the first surgeon. International Society of Otology bears the name of a person who dedicated 50 years to otology. Who is he? All quizzer. AOI West Bengal is known for its quizzes among students here. Huh? No, it's Adam Politzer. You have heard of this man? Wild's incision, right? You do it sword surgery. Now, he had a very famous son, Oscar Wilde. Excellent. Now, what is his coincidence with otology? Besides that his father was a great thing. He had an infection. I think the point can be given. Soman will give. He died because of autogenic meningitis. Right. So, any questions? I think Dr. Ajay gave you a very, very simple case. A patient is coming in the history. Now, I want to ask you, I'll just twist the history a little bit. This patient underwent a surgery 15 years back, ear surgery. Now that 10 year and 8 years of hearing loss. After the onset, he again underwent a surgery in the ear because he developed a swelling behind the ear. Get it? Surgery before, he must have had a tympanoplasty, failed tympanoplasty. Now he has developed a squamous disease. And while the squamous disease, he developed a complication which is abscess and which was operated in between. And now that operation was, one incision was given and he got okay. And now he has come to you with this history. So, how will you now frame your history taking? Mike, onset I have told you already. The patient had a surgery before tympanoplasty. Now that 10 years he is having this kind of discharge, right? While the discharge was going on, 3 years later he developed a swelling behind the ear which was very painful and fever, and it was incised by a local quack, and the patient was okay, and now he has come to you. You will get these kind of cases in the exam.
The presenting symptoms, presenting complaints.
So what will be the presenting complaints?
His ear discharge, that will tell.
10 years?
10 years.
Okay. And hearing loss 8 years?
Yes, sir.
Now how will you start your history presentation? Will be the
first
previous, what is the first line you use? Previously asymptomatic patient. Now when is the patient symptomatic from?
So we go chronological order. The first onset of the first symptom. From there we start the.
So that is the present illness, no?
Yes, sir.
So there is a contradictory in what you are saying. You are going to get these kind of cases, and I have seen examiners questioning you on this. Ki when is your presenting illness? Will you put it 20 years back when he had his first discharge, or will you put it now?
So the 20 years back, the first symptom that we are supposed to.
The second part of the topic, stick to and defend what you are saying. That is all. You should know how to defend. Okay, sir, the actual onset of the disease is 20 years. So my present illness is previously asymptomatic patient started 20 years back. Okay, and then you can start. There is no issue again. If you try to start 10 years, then going back, you will get confused. Examiner will get confused, and that is the end of it. And God forbid, if you are the 4th or 5th student, his mind is already troubled, right? So I think that is more or less. Good luck and best wishes to all of you. Thank you.
So we have come. We will conclude the first session on the default long case, that is the chronic otitis media. Remember that the result of the surgery may be dependent on the surgeon and also on the disease itself. So there are some surgeon specific causes of failure, some
disease specific causes of failure also. So remember which are the factors that give you the best results after surgery, the TRACS principle, the surgeon related problems, and the disease related problems that may give you unsatisfactory post-operative results. So I think that concludes the session. If you have any further queries, you can submit your queries and we will be happy to answer those queries. There will be a 5-minute gap, a 5-minute recess. If you want to go to the washroom, go there, but we will, after 5 minutes, we will start with the rhinology session.
হ্যালো, আচ্ছা আমরা আজকে সেশনে সব তো কভার করতে পারি না, কয়েকটা আমার সাজেশান ছিল, সেগুলো তোমরা লিখে নাও, সেগুলো একটু স্টাডি করবে। হ্যাঁ, একটা হচ্ছে ডিফারেন্স বিটুইন কোলেস্টিওটোমা ইন কেস অফ চিলড্রেন অ্যান্ড অ্যাডাল্ট। আমি এখন অ্যান্সার বলবো না, লিখে নাও। সেকেন্ড হচ্ছে এ সাডেন in a case of COM, sudden onset of facial palsy, how will you manage? Third, in a case of squamosal COM, sudden onset of vertigo, how will you manage? এগুলো পরীক্ষায় জিজ্ঞেস করা হয়। থার্ড হচ্ছে হঠাৎ ইন্টারক্রেনিয়াল কমপ্লিকেশন অফ COM and how will you manage that? ঠিক আছে। থার্ড, নেক্সট হচ্ছে হোয়াট ইজ কগ, হোয়াট ইজ দ্য সার্জিক্যাল ইম্পর্টেন্স অফ কগ, হোয়াট ইজ কর্নার সেপ্টাম, হোয়াট ইজ দ্য সার্জিক্যাল ইম্পর্টেন্স অফ কর্নার সেপ্টাম। আরও আছে, আর কক্স আছে, অ্যান্ড এন্ডোস্কোপিক ভিউ অফ মিডিলিয়ার ক্যাভিটি, এন্ডোস্কোপিক ভিউ অফ what are the types of sinus tympanum, what is ফুস্টি, সেসবগুলো জিজ্ঞেস করে পরীক্ষার সময়। আমি একজন এক্সামিনারকে দেখে যাই এন্ডোস্কোপিক অ্যানাটমি প্রচুর জিজ্ঞেস করছিল, মিডিলিয়ার অ্যানাটমি, তো ভালো করে পড়বে, ঠিক আছে।
We have the group in the PG teaching group, so any teachers can give the whatever they want the questions. They can group put the any teacher can put the questions for the student for the better. Okay, 5-minute recess. We will start the rhinology.